This conference will now be recorded.
Okay. So today we are going to do two talks. One is management of ovarian cysts in children and adolescents, and another one is urethral bulking agents. Both are April 2020 talks. So coming to the first talk, that is management of ovarian cysts in children and adolescents. So in children and adolescents, the more ovarian cysts they commonly present either during neonatal period, and the peak incidence occurs in first year of life and around the time of menarche. So these are the two peaks. Okay, so one is first year of life and another is time around the menarche. So neonatal ovarian cysts, these are the most common cause of abdominal cyst in female fetuses and neonates, usually present in the third trimester. The most are unilateral and simple in nature, but they can be of varying size. The cause is because of fetal gonadotropins, maternal estrogen, and placental SCG. Complications of antenatal and neonatal ovarian cysts include same acute accidents like rupture, torsion, hemorrhage, and compression of nearby structures. In first year of life, volume of ovary is around 1 ml. So reduction in estrogen level after the childbirth, okay, because at birth the estrogen is mostly because of maternal origin. So after that, this reduction in estrogen level, it causes reduction in the size in the second year of life. Still, follicles can be seen in 84% of ovaries in girls under 2 years of age. So after the reduction in the estrogen, all these follicles and all these cysts, they usually disappears. They regress spontaneously, but this can take several months. Usually, management for this neonatal ovarian cyst is conservative. It may involve serial scans, but if the cyst is very large or if any accident occurs, like torsion is suspected, then surgical management is considered, and this surgery should be performed by pediatric surgeons. So this is for the neonatal ovarian cyst. Now coming to the ovarian cyst in children and adolescents. So most ovarian cysts in children and adolescents, these are benign, and 60% are functional simple ovarian cyst. What happened? What is the etiology of this functional ovarian cyst is ovarian follicle failed to involute and mature into the corpus luteum. Okay, so there will be no involution and there will be no formation of corpus luteum. So they are just like a bigger follicles. Okay, same hyperechoic. What you can say, it is a uniform black colored cyst, simple cyst that you can see on the ultrasound. They are thought to be caused by intermittent gonadotropin production by developing pituitary gland. Most of the times they will resolve spontaneously. There was a study which is conducted in the premenarchal girls presenting with pain. It showed that incidence of this ovarian cyst is 1.8 to 15% and it increases with the increase in age. So simple ovarian cyst, it is a common adnexal finding at laparoscopy for acute abdomen in young girls. Often it requires no intervention. Now see, this is again one question. It was a recall question, but the patient is being operated for appendix, okay, by a surgeon, and during laparoscopy, it is intraoperative finding of 3 centimeter ovarian cyst. What you will do? So here it requires no intervention is the answer there. Okay. Paratubal cysts can be confused with simple ovarian cysts. They can grow quite large and they do not tend to resolve like functional cyst. If the cyst is large or patient is in pain. So if it is symptomatic or if it is very large, it can be managed by laparoscopically. Mid-cycle pain in postmenarchal girl, it is usually associated with functional hemorrhagic cyst. This may be associated with some free fluid or hemoperitoneum, but usually this reabsorption of fluid occurs and they resolve spontaneously. Coming to the benign ovarian tumors. So till now we were discussing regarding the simple cyst. Now, if the cyst is complex, okay, if the cyst is complex in young girls or children, they are usually germ cell tumors and these are almost benign. Benign germ cell tumors, these are the most common in children and adolescents, and of this 55 to 70%, these are the dermoid cyst or macrocystic teratomas. So most of the complex ovarian cysts, this can again come as a question. So most complex ovarian cyst on ultrasound in almost you can say adolescent girl. So the diagnosis will be dermoid cyst. They usually occur between the age of 6 to 15 years. 10% can be bilateral. They are usually asymptomatic and usually discovered accidentally on ultrasound scan. 15% can present with pain and torsion. So torsion occurs in 15%, bilaterality is present in 10%. Spontaneous rupture occurs in less than 1%, and malignancy occurs in around 1.7%. So these are the numbers that you should remember for this dermoid cyst. Okay, 10% bilateral, 15% torsion, less than 1% rupture, and malignancy in 1.7%. Rare complications of dermoid cyst are carcinoid tumors, struma ovary, hemolytic anemia, and anti-NMDA receptors encephalitis. Then coming to the other benign tumors are gonadoblastoma of mixed germ cell tumor. Okay, this is usually present in gonadal dysgenesis patient when there is a presence of Y chromosome. Okay, so gonadal dysgenesis, where you can see that is androgen insensitivity or Swyer syndrome. Here there can be gonadoblastoma can be there with mixed germ cell tumor. It is benign, but it can evolve into dysgerminoma, which can have malignant features. Coming to the malignant ovarian tumors in children and adolescents. So half of the malignant ovarian tumors in children and adolescents, these are juvenile granulosa cell tumors. Okay. So see, first is the maximum tumors will be, first 60% will be functional cyst. Okay. Of the remaining is, most common is benign germ cell tumors, which is most common is mature teratoma or dermoid cyst. Now, if the cyst is malignant, then malignant cysts, almost 50% are juvenile granulosa cell tumor. Okay. So remember the order sequence. Remember the sequence. So first most common is simple ovarian cyst. After that dermoid. After that juvenile granulosa cell tumor. These are usually solid tumors and these are most common form of sex cord cell tumors. Half are diagnosed, they are between age of 6 to 13 years. 1/3 are diagnosed between the ages of 14 to 19 years. 95% patients, they present with tumor limited to ovary and they have more than 90% survival rates with surgical resection. Most of the tumors are unilateral, while 2 to 5% can be bilateral. The most common presenting feature of juvenile granulosa cell tumor is pseudo-precocious puberty, including pigmentation of breast areola, breast enlargement, vaginal discharge, pubic hair growth. These are usually estrogen secreting tumors. These are granulosa cell tumors, so they secrete, most commonly they secrete estrogen. But sometimes they can present with excessive androgen secretion like clitoromegaly, hirsutism, deep voice, irregular periods, or amenorrhea. So these are again keywords. Young girl presenting with any of these features, either with pseudo-precocious puberty or with amenorrhea and acromegaly, hirsutism. So all these are features of juvenile granulosa cell tumors. This is again, I think it was a recall question in at least 2 to 3 times. Now, after this juvenile granulosa cell tumor, so this is the most common malignant tumor. Okay. After this, the next common malignant tumor is malignant ovarian germ cell tumors. These account for 1.5% of ovarian cancers. And of this, 1/3 are dysgerminoma, 1/3 are immature teratoma, and other third they include embryonal tumors, endodermal synapse tumors, choriocarcinoma, and mixed cell type. So, in the malignant germ cell tumors, the common is dysgerminoma and immature teratomas. Most emogicity, they occur in first 2 decades of life. Early diagnosis and multi-agent chemotherapy, they are associated with high cure rates. Cure rates are almost more than 90%, and risk of premature ovarian failure is low at 3% even after this chemotherapy. Yes? Yes, any doubt? Okay. So, immature teratomas, they are defined by the presence of variable amounts of immature neuroepithelium. See, this is the feature that is differentiating between immature and mature teratoma. So, dermoid tumors or dermoid cysts, they do not have any immature neuroepithelial cell. So, this is again, I think, there was 1 or 2 questions in the books. Okay, so glial cells, presence of glial cells, it's suggestive of immature teratoma. It's presence of neural tissues. Okay, most are unilateral, but they can be bilateral or have mature teratomas in contralateral ovary. They can occur on their own or as a part of mixed germ cell tumor. Ovarian neoplasm in childhood and adolescence, they can be associated with other cancer predisposition syndrome like Oliver disease, Maffucci syndrome, Peutz-Jeghers syndrome, Frazier syndrome, and Dicer-1 syndrome. If such syndromes are identified, patient should be offered the possibility of surveillance for other cancers. Now, presentation of this ovarian cyst and how to differentiate between the causes. So, most common presenting complaint are abdominal pain and distension. So, pain is common in around 30% of patients. Ovarian torsion occurs in 7 to 10.5% of ovarian cysts diagnosed in children and adolescents. Acute tubovarian torsion, it must be excluded early when pain is acute, unilateral, associated with vomiting and tachycardia. So these are the keywords for the diagnosis of torsion. Now here there is no well. Okay, patients are more likely to experience longer duration of fever. Remember, duration of pain, which is constant or colicky, while in appendicitis, it migrates. Okay, but in this, it does not migrate. Age of torsion in years, and it is more common on the right side. Why right side? Because on left side there is a sigmoid colon which is relatively fixed. Okay, and on right side the cecum is mobile, which permits movement, and on right side the mesosalpinx is slightly longer and longer ovarian ligament. So all these conditions predispose to the torsion, more common on right side. So differential diagnosis for pelvic pain in children. Now see, they have given all the different diagnoses for different age groups. So for children, DD will be appendicitis, urinary tract infection, constipation with loaded colon, intussusception, volvulus, and mesenteric adenitis. These are the children's. Okay. In adolescent, DD will be endometriosis, obstructed Mullerian duct anomalies, PID, and ectopic pregnancy, because they can be sexually active there. Abdominal distension, it can occur from a large ovarian cyst and may be associated with pressure symptoms, urinary frequency, pain, and breathlessness. Rarely, fibromas, thecomas, and granulosa cell tumors of ovary, it can present with hydrothorax and non-malignant ascites, which is known as mixed syndrome. So, mixed syndrome tumors are fibromas, thecomas, and granulosa cell tumors. So, always in younger patient, whenever they present with complex ovarian cyst, always one should look signs for precocious puberty and hyperandrogenism, because if these are present, they will suggest that it is a juvenile granulosa cell tumors. Now in neonates, the differential diagnosis for this pain in abdomen is UTI, Hirschsprung disease, incarcerated hernia, intussusception, Meckel's diverticulum, and volvulus. So these are the different differential diagnoses that you should remember according to the age group. Now investigations for ovarian cysts. So first and foremost investigation is transabdominal pelvic ultrasound. Now remember, it is a transabdominal because these are children and adolescents and they will not be sexually active. Okay, sensitivity and specificity of 94 and 98.2%. It is easy to perform and cost-effective investigation, but it requires full bladder to enable to visualize ovaries. If a complex ovarian cyst is diagnosed on ultrasound, MRI can be requested. Just okay. So if on the ultrasound, if there is a presence of complex ovarian cyst, then you can do MRI. MRI, why MRI? Because it provides good soft tissue delineation and it allows identification of different ovarian tumors. Okay, so you can differentiate between the types of ovarian cyst. But young children, they require sedation because of this length of examination. So depending upon the findings, the case can be discussed with gynecology or pediatric surgical oncology, MDT, and discuss with gynecologists with special interest in oncology. Okay, so depends, we have to divide whether this tumor belongs to a benign or malignant variety, and depending upon that, the further management will depend. Transabdominal ultrasound, it should be performed in presence of an acute abdomen. If an adolescent is sexually active, then they can also do transvaginal ultrasound. So if there are any complex features with suspicion of malignancy, now see, routine complex ovarian cyst, you will do MRI. Now, if you are suspecting any malignancy in case of complex cyst, okay, then cross-sectional imaging of pelvis, and it is usually done by CT, okay, because it does not require sedation, and also you can use contrast, okay, and it is used to identify the bowel, and contrast is useful also for the identification of metastasis. Other tests for ovarian cysts, it include full blood count, C-reactive protein, tumor markers like AFP, SCG, LDH, and cancer antigen CA125, urine dipstick, and when indicated, endocervical swabs if the patient is sexually active. Tumor markers is used to identify the different types of neoplasms. Malignancies, these are present in less than 1% of simple cysts. So, in presence of large and persistent simple cysts, tumor marker level should be done. So, routinely for simple cysts, tumor markers are not required, but if they are large and persistent simple cysts, tumor marker should be done. What is the role of WBC and CRP levels? So, these are the markers for inflammation, and they can be raised in presence of ovarian torsion. But normal values do not rule out torsion. Also, sterile pyuria is seen in presence of ovarian torsion, and it can mimic urinary tract infection. So this is the differential diagnosis you should remember. Okay, if you get pyuria, if it is sterile, it can be due to ovarian torsion. If there are any signs of precocious puberty, a complete hormonal profile, that is FSH, LH, estradiol, and thyroid function test should be done. Now, how you are going to identify in case of acute abdomen torsion? So it is usually done by ultrasound and Doppler. So unilateral ovarian enlargement and edema, these are the most consistent sonographic findings in case of torsion. The ovary may have ill-defined border, and there may be peripheral arrangements of follicle, especially in prepubertal girls. Also, there is always abnormal Doppler signals in ovarian vessels with either absent peripheral flow or coiling of ovarian vessels in subacute cases. Okay, so these are the markers, or these are the signs on ultrasound in case of torsion. Now, tumor markers suggestive of various tumors. So, alpha fetoprotein, it is elevated in immature teratoma, Sertoli-Leydig cell tumor, yolk sac tumor, and embryonal cell carcinoma. SCG is elevated in dysgerminoma, embryonal carcinoma. LDH is elevated in dysgerminoma, again immature teratoma. CA125, epithelial tumors. CA, again epithelial tumors. Estradiol is elevated in granulosa cell tumor. Testosterone in case of Sertoli-Leydig cell tumor. Now coming to the management of this ovarian cyst. So when the patient comes with ovarian cyst, first you have to rule out any acute event. So if the patient has come to the emergency with acute abdomen, always you have to rule out torsion. Okay. So first and foremost thing you will be doing is the ultrasound imaging, and to inform the surgery if available within 4 hours of admissions and clinical condition. So within 4 hours, the ultrasound and surgery should happen if the patient comes in emergency with acute abdomen whenever there is suspicion of torsion. Now, in case of torsion, surgery of choice is laparoscopy with ovarian sparing. Okay, and request on-call gynecologist for input. So we will see in detail regarding this torsion management again, but it is the most important thing that you should rule out when the patient comes with acute abdomen, because there are concerns of future fertility if the ovary becomes gangrenous. Now, if the patient is come with asymptomatic or pain in abdomen, which is not very severe, any menstrual problems or precocious puberty. So in all these cases, you will be first doing transabdominal scan. Now, on the transabdominal scan, first you have to see whether it is a simple cyst or complex cyst. If it is a simple cyst, you have to see the size of the cyst. So if the size of cyst is less than 3 centimeters, there is no further follow-up because it is going to resolve on its own. Less than 3 centimeter doesn't require any follow-up. If the simple cyst is between 3 to 5 centimeters, you will do rescan in 3 months for reassurance. Premenarchal girl, you can review in specialist pediatric adolescent gynecology clinic. Now the cyst between 5 to 7 centimeters. So if the cyst is asymptomatic, you will do rescan in 3 months. If it is resolved, no problem, discharge. If it persists, you have to do tumor markers and MRI. Okay. And depending upon these results, you will decide further management. If the cyst is more than 7 centimeters, you can directly go for lap ovarian cystectomy, or if you think that it is asymptomatic, then you can do the rescan in 3 months. Okay. So this is the management for the simple cyst. Now, if the cyst is complex, then in case of complex cyst, you require further investigation. So what are the further investigations you will be doing? Is tumor markers, that is AFP, SCG, LDH, and CA125, and MRI. If there is no suspicion of cancer, in case of symptomatic more than 5 centimeter cyst, you will be doing lap cystectomy. While in case of suspicion of cancer, you will refer to the oncology MDT. So all children or young girls who have undergone this surgery, they should have follow up after surgery to discuss the findings and implications on future fertility. This is most important. So after surgery, there should be this one visit, which is for this regarding discussion of the findings and implications of future fertility. Okay, so this is overview of this management. Now going to in details of this management. So what they have given in this talk is that cystic most mature, that is most dermoid cysts, they grow slowly at the rate of 1.8 millimeter per year. So they can be monitored conservatively. If a mature cystic teratoma or dermoid cyst, if it is less than 5 centimeter, conservative management with serial scan. What is the basic problem with dermoid cyst surgery is, with laparoscopic surgery, the main risk is intraoperative cyst rupture. There is a risk of spillage, and if it is malignancy, it can lead to upstaging of the tumor, chemical peritonitis, and adhesion formation. So to avoid any spill, a tissue bag can be used to collect cyst content, or laparotomy can be considered. So it depends upon the size of the cyst, but then there is no mention regarding at what size you should go for laparoscopy and what size you should go for laparotomy. The risk of chemical peritonitis in case of dermoid cyst is less than 0.2%. Risk of recurrence must also be considered with laparoscopic surgery for macrocystic teratoma. So what happens? Recurrence rate is around 10.6% in one study, and there was no significant impact on type of surgery and dermoid recurrence. So it is not that laparoscopy surgery, it increases the risk of recurrence. Okay. What are the points which are important for this recurrences? Young age, large cyst size, and bilaterality. These are the predictive factors for recurrence. Drainage and aspiration, it should not be used because it is associated with high rate of recurrence, that you already know. Now coming to the management of torsion. So if torsion is suspected, prompt investigation and intervention is required to avoid any long-term effects and to prevent oophorectomy. So this is the most important thing of management. So current recommendation is detorsion with or without cystectomy, even if ovary looks necrotic. Remember this well, okay? Because this is the thing, you get repeated questions on this. So even if the ovary is necrotic, you should only do detorsion and cystectomy. Ovarian function has been proven in multiple studies following detorsion of a blue bag ovary. There was a concern regarding thromboembolism also with this detorsion. Okay, but now new studies, they have found no basis for this concern. Now when you will do this oophoropexy or fixation, okay, gonadopexy or fixation after detorsion, it can be considered when in case of previous oophorectomy and presence of unilateral torted ovary. In this case, to prevent further recurrence, you can do oophoropexy, but it is not routinely done. And again, it is important to note that this oophoropexy does not completely prevent ovarian torsion. So for all cases, this gonadopexy is not recommended. Only in case of already oophorectomized patient with unilateral torsion, it is the indication for oophoropexy. Now, who should do this surgery and who should manage this ovarian cyst patients? So each hospital should have their own protocol. There should be a multidisciplinary approach with pediatric and adolescent gynecologists. They should be involved whenever possible. Now, who should operate? So the most appropriate clinician to operate is one who can competently perform minimally invasive surgery, and it should be ovarian preserving surgery. Okay. When performing ovarian cystectomy, utmost care should be taken to preserve ovarian tissue. In suspected malignancy, you should always involve oncology MDT. Follow-up should be arranged with pediatric and adolescent gynecologists or gynecologists experienced in caring for pediatric patients, okay, after emergency or elective surgery to discuss the finding and future implications of fertility. Coming to the communication and consent for these procedures. So chaperone should be always present for examination. So the chaperone can be nurse, play specialist or similar professional. Parent should also be present unless the patient specifies otherwise. So if the patient doesn't want her parents to be present, okay. Otherwise, parents should be present. Always explain to the patient and her parents regarding exactly what the examination will involve. Vaginal examination, speculum and transvaginal ultrasound, it should not be used, should never be used in girls who have never been sexually active. Even teenagers who are sexually active, they can decline vaginal examination or speculum examination. Now, as I told you, you have to fix another appointment after surgery because there can be considerable anxiety and concerns regarding her future fertility and malignancy risk. So it should be discussed with them and reassurance should be given. Okay. Also, family should receive written documentation and patient information leaflets. So this is regarding the consent. So this is for this ovarian cyst in children and adolescent talk. So this is the question. Please answer in your chat box. Yes, because it is beta HCG plus LDH is raised, so it is a dysgerminoma. Next one. Yes, it is a precocious puberty, correct? So this is juvenile granulosa cell tumor. So answer is E here. Just please 1 minute. I have to make one important call and then we will go to another talk. Just 1 minute, please. Okay. So the next talk is regarding use of urethral bulking agents in the treatment of SUI. This again April 2020 talk.
Ma'am, I
Yes.
had a doubt in the previous,
Yes. Yes.
ma'am, regarding
Yeah.
the investigations. Ma'am, you
Hmm.
said that the first investigation is transabdominal ultrasound. Ma'am,
Correct.
then in case of inconclusive results, then we can go for MRI. And ma'am,
Yes.
when do we go for contrast CT?
If you are suspecting malignancy, if there is a strong suspicion of malignancy, see, just if you find that it is a complex cyst, it is not inconclusive. In case of complex cyst, you will go for MRI. Okay. Simple cyst doesn't require any further imaging. Okay. That ultrasound is sufficient. In case of complex cyst, you will go for MRI. Now, if there is a bit complex cyst, if you apply this aorta and you find that there is a strong suspicion of malignancy, then you will go for CT. Okay.
Okay, okay, ma'am. Ma'am, not depending on the age group, like if it's a neonate or a
No, no, no.
child.
No, it is
Okay.
not. It is not given. It is not specified in the talk also, and it is not. It is only depending upon the characteristics. Okay, not depending upon the age group. Now, one thing is there. MRI, see, neonate tolerating MRI is very difficult. Correct?
Yes, ma'am.
Yeah. So for neonate, if you get complex cyst, then better to go for CT in that case. Okay. Hmm?
Okay, ma'am.
But still, usually neonate, there are very less chances of malignancy. They are mostly the simple cyst only. Okay. So the problem of malignancy arises in case of children and adolescents. So for older children, like more than 8 years, they can go for MRI, correct?
Yes, ma'am. Yes, ma'am.
Yeah.
Okay.
Okay. Yes. So coming to this urethral bulking agent talk. So urinary incontinence means any involuntary loss of urine. Large community-based study shows that 25% patient, so prevalence of urinary incontinence is 25%. Okay. And of that, most common is SUI. It present in 50%. 36% has mixed and 11% only urgency incontinence. Pathophysiology of SUI. So it is the SUI, it is the involuntary loss of urine associated with any effort or exertion like sneezing, coughing or exercise. The reasons of SUI is most commonly it is a urethral hypermobility during rising intra-abdominal pressure, which is usually caused by pelvic floor damage during childbirth with loss of normal urethral support. So most common cause of SUI is urethral hypermobility. Okay. Clinically, this urethral hypermobility is present when there is descent and anterior rotation of anterior vaginal wall is observed during a cough. So you have to ask the patient to cough. You can see there is a descent and anterior rotation of anterior vaginal wall and it is present with urinary leakage. So it confirms it is a urethral hypermobility. Now in other patients, this SUI reason can be urethral weakness or intrinsic sphincter deficiency, which occurs in absence of significant urethral hypermobility. These cases, this SUI is most commonly observed during coughing when the urethra appears to be fixed and rigid, and it is characteristically observed in women with failed surgeries for SUI. Okay, so see, this can come as question. Patient has already had undergone a surgery for SUI, and now she again has recurrence of SUI. What can be the cause? So this is the mostly because of intrinsic sphincter deficiency or primary urethral weakness. Okay. Although ISD and urethral hypermobility, they have been considered separately, women with SUI, they are likely to have a spectrum of which incorporates this both etiologies. So there can be a both, they can coexist together. Now coming to the treatment of SUI. So first and foremost treatment will be lifestyle modification. That means limiting fluid intake, reduction in caffeine and alcohol, smoking cessation and weight reduction when BMI is more than 30. All women, they should be offered a trial of PFMT, that is supervised pelvic floor muscle training for at least 3 months duration as first line treatment. Intensive PFMT is effective in the treatment of SUI. Patient with stress predominant mixed urinary incontinence also should be advised that the benefit of non-surgical therapies for overactive bladder. Now, if the patient has mixed urinary incontinence, you will first advise her to How this? If she is having stress predominant, then you will advise all this modification PFMT, and before offering her surgery, you will offer drugs for overactive bladder. Okay. Before going for the surgery for SUI, in case of mixed urinary incontinence, you will first offer treatment for overactive bladder. Then NICE does recommend this use of mechanical devices only occasionally, that is during exercise. Then you can use this pads, plugs, and all these things. Otherwise, these are not routinely recommended. Drugs like duloxetine, they are also should be reserved for the patients who prefer pharmacological treatment than surgical, or who are not suitable for surgery. So this is the third line of management, duloxetine. Now, what is the role of surgery in SUI? So surgery should be offered only when conservative management fails. Surgery can be done without urodynamic testing for pure SUI or stress predominant MUI, which is diagnosed by history and demonstrated on clinical examination. So urodynamics is not required for surgical management of pure stress incontinence. In the past 2 decades, the main surgery for SUI was use of mid-urethral tapes, or you can call it as either TOT or TVT. Okay, only a minority of women have undergone these non-mesh procedures. But then complications of these mesh tapes, they have gained widespread public attention and scrutiny. So, and what was there? There was a reoperation rate of 6.9% for either tape removal or repeat surgery, and also almost 10% rate of complication for this mesh surgery. So for this, in 2018 July, National Pause for Vigilance with Mesh Restriction, it was implemented. And then pause restriction, they has been also extended until conditions set by NICE have been fulfilled. That means creation of national register and identification of specialist removal center. So till now, this ban means vigilance continues. That means when the patient wants to have this mesh surgery, you should always do in presence of regional MDT. You should always give her option of other surgeries first, and then you have to explain to her that it is a permanent surgery and removal may be impossible sometimes, not always, but sometimes the removal may be impossible and complication can occur. So this is the thing that counseling is required in case of mesh surgeries. Now the classification of this SUI surgeries. So first is augmentation for sphincter tone. Okay. So to augment this urethral sphincter tone, the procedures available are bulking agents and artificial sphincters. Operation to suspend the vaginal wall. One is scalpo suspension, second is mid-urethral tapes, and third is autologous slings. So these are the most common surgical procedures. These are used for this SUI. And the things which are no longer recommended is neck needle suspension. Bladder neck suspension is not recommended. In most recent NICE guideline, women should be offered the choice of either open or lap colpo suspension and autologous rectusfacial sling. These are the first. So always the first option will be colpo suspension. Second option will be autologous rectusfacial slings. Retropubic mesh slings, they can be also included as an option, but as I told you, thorough counseling is required. They should be entered in National Database Registry, and regional MDT should be involved for this mesh surgeries. Usually TOTs, that is transobturator approach, should not be used, and top-down approach should not be used. Okay, so these two are avoided. TOT is avoided and top-down approach is avoided. A retrospective review of this surgery for pelvic organ prolapse, it has shown that there is 48% reduction in mesh procedure from 2008 to 2016. Okay, so with this pause on this mesh surgery, urethral bulking agents, they are likely to gain popularity. So indications for these urethral bulking agents are women who wish to avoid major surgery or mesh, recurrent SUI after previous failed surgery, women who accept the lower cure rate in favor of less invasive procedure with lower risk of voiding difficulty, women with other comorbidities which precludes invasive surgery which requires anesthesia. Also the young woman where future fertility is desired prior to definitive treatment. This is also an indication for bulking agents that you should remember. Now how to counsel the women when they want to have this bulking agents. So the women who are considering bulking agents, they should be made aware that they are permanent materials. Repeat injections may be required to achieve efficacy. Efficacy is inferior to other surgical options, and durability is poor, and there is limited evidence on long-term efficacy and adverse effects. So all these things should be counseled to the patient. Also, NICE recommend that the woman should be provided written information regarding the name of the agent, manufacturer, date of injection, and the surgeon's detail. Which are the 5 bulking agents which are currently available in UKR? Polyacrylamide, that is Bulkamid, polydimethylsiloxane, that is macroplastic, carbon beads or Durasphere, calcium hydroxyapatite, that is Coptite, and cross-linked vinyl dimethyl polydimethyl siloxane, that is Urolastic. So all these are available in UK right now, but most commonly used in UK are microplastic and Bulkamid. Okay, so these are the 2 things which are replaced collagen as the agent of choice because they do not require skin testing prior to admission. Okay, they do not require skin testing. Now coming to the each agent, remember well non-particulate agent is polyacrylamide, that is or Bulkamid. Okay, so this is a non-particulate agent while all others are particulate agents. Here basically it because this is a non-particulate agent, this is bulking effect is caused by volume designed to allow ingrowth and proliferation of blood vessels and the invasion of giant cells. Okay, while in all particulate thing that you should remember that it should not migrate. Okay, so here in silicon particles or microplastic, the particles are more in diameter, so they reduce the migration risk. Okay, also these carbon beads, they are having minimal risk of migration and they are durable. This cooptite is non-immunogenic because it is a normal constituent of bone, while this urolastic, it was previously used for hysteroscopic sterilization. Now, mechanism of action of bulking agents. So usually what happens in to avoid or to prevent this SUI, the urethral mucosa should adapt in such a way that it should remain closed at rest in process called as cooptation. And this usually occurs because of this presence of submucosal cushions and smooth muscle activity which encourage the continence. So this intramural bulking agent, what they does is they create additional submucosal bulk by providing artificial mucosal cushion. So this is cushioning effect is there with this bulking agent, and also they improve the contractility of the sphincter. Okay, by providing the additional centrifugal volume, which increases the length of muscle fiber. Now, the ideal bulking agent, it should be easy to inject, it should retain volume and durability. It should be biocompatible with minimal inflammation, minimal fibrosis, and there should be no migration. But currently, no such agent is available which have all these properties together. Bulking agents, they are more effective than the pelvic floor muscle training in short term, but they are associated with complication and the efficacy may not be sustained in longer term. Bulking agents, they are less effective than other surgeries like open or pubovaginal sling procedures, and there is higher recurrence rate, but there are generally fewer complications in the injection group with lower rate of voiding dysfunction and similar satisfaction rate in short term. In the most recent Cochrane review, they have identified that there is wide variation and heterogeneity in sample size, patient characteristics, types of intervention. So what they have decided that present evidence is not adequate to recommend bulking agent as a first line treatment for SUI. So it remains always a second line treatment. Bulking agents, these are less effective than traditional sling procedure as a first line therapy when followed up in long term. This may represent a shorter duration of cure and requirement of repeat injection. So over the short term, the bulking agent is an effective agent, effective therapy, but over long term, it is not an effective thing other than to other surgeries. Complications of bulking agent. So most adverse effects are minor and transient like UTI, infection, pain, transient hematuria, and dysuria. These are the most common. This complication rate is around 32%, and these most complications are minor and transient. There is 3% risk of major complication which requires additional procedures. So major complications like hypersensitivity reaction, injection site complication like sterile or infected abscess, pseudocyst formation or mass formation, prolapse or diverticular formation, or overactive bladder. So these are the things which can require further procedure. Also, other major complications like pulmonary embolism and death, it can caused by the migration of bulking agent. It has been happened with this autologous fat injection. Okay, so now it is no longer used. Operative technique of this bulking agent injection. So now they have given in details regarding the Bulkamid, okay, but I have not included because nobody is going to ask you what is the technique, but what are the major points in these techniques that I have included here. So before this surgery, preoperative urine analysis should be done in all patients for screening of UTI. Antibiotic prophylaxis may not be, so antibiotic prophylaxis is not essential, but it can be given. Bulking agents, these are usually administered during cystoscopy using 0-degree lens under local or general anesthesia, and the position is lithotomy. Injection, either it can be given transurethral or periurethral. So transurethral injection, it should be done by cystoscopy, while periurethral injections, they are delivered transcutaneously using long injection needles. The injection device similar to dental syringe is usually necessary to allow passage down the needle because of viscous nature of most bulking agents. So it requires a long needle, okay, dental needle. The bulking material is injected into the urethral submucosa at 2 or more sites. So it is the submucosal injection at 2 or more sites at the same level, just distal to bladder neck or into the mid-urethra. So site of injection is bladder neck or mid-urethra. So this is the basic thing. It should be injected. It is injected in these 3 places, that is 6 o'clock, 2 o'clock, and 10 o'clock. Okay, and 1 ml is injected is 6 o'clock. 0.5 ml is injected in 2 and 10 o'clock. What they until the bleb formation is observed. This bleb creates this artificial cushioning effect. Regarding long-term outcomes, as I told you, there are no good studies or further research is required for this longer-term efficacy. Also, which technique and which site of injection. Also, so all these things requires further studies and which should have a rigorous comparison with other surgeries. Coming to the ethical issues. So when you consider bulking agent as a first-line agent, you should always remember what happened with this tape surgeries or mesh surgeries. So mesh surgeries has become most popular in the last 20 years, but finally because of complication, it has gone into this banned procedure. So always you should remember this story before giving this option as a first line agent, okay, because there is no long-term evidence yet, and also complication rates are still unknown. Okay, also history has shown that some bulking agents, they did not stand the test of time with initially promising results. Also important that women should receive appropriate counseling regarding the nature of the agent, regarding the efficacy, and regarding the complications. Okay, so all available information and all available treatment options should be given to the patient, and you should always insist on this lack of long-term data of these bulking agents. Also develop high quality and robust patient information reflects, and if relevant expertise is unavailable, there should be onward referral to the another specialist with MDT. So this is regarding this bulking agent talk. This is a single question which is there for this bulking agents. So please type in your answer box. Hello, Chapu? Yes, because she requires future fertility. Okay, so that permanent options you can't give to her unless her childbearing is completed. So that's why transurethral bulking agent is a good option for her. So answer is E here. So this is regarding these two talks today. Tomorrow we will again discuss one or two talks tomorrow. Okay. I think I have completed with this 2020 talks because Jan 2020 talk this thing issue I already discussed and you will find those lectures in the YouTube. Okay, those sessions are uploaded in YouTube already, so you can go through it. I think I have completed all the January 2020 before the September examination, September exam. So I think we will now move on to this 2019 talks from tomorrow. Okay. So thank you.
Ma'am,
Yes.
ma'am,
Yeah.
if you have January 2020 summaries, can you please forward them? We can at least read them. If you have summaries available.
See, already the recordings are available. Summaries are also, I think I have given in these recordings only. Okay.
Okay, you have given. Okay. Okay.
Yeah. Okay then.
Thank you,
Bye for
ma'am.
now.
Thank you, ma'am.